Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 154. Welcome from Mount Sinai, New York on a lovely spring morning. We have another fascinating case today, hopefully with a lot more tips and tricks. Back to doing diffuse calcified disease, probably with aided by some OCT imaging. Let me take you to the Cardiac Cath lab where the case is ready, and Dr. Kinney and Dr. Sharma are there. Samin, good morning to you and your team, and congratulations. I've just scanned over some excellent reporting from the New York State for the hospital.
Yes, good morning and good morning to our viewers from Mount Sinai Cath Lab. And this is a continuation of our educational mission. We'll show the complex case today, just like multiple steps which were emphasized last time. And yes, the New York State actually after almost a hiatus of 2 years came with a report of 2018 still. And that's we'll share with you, and of course there are some very good and some not that good the points in the report, which always happens, but really we are very fortunate to our viewers which have been tremendous over the years, and asking what type of case. And so this is the case which we are going to do today with the multiple lesions whom already has ISR. And so with that note, if okay, we go with the slides. So this is actually the report of the 2018, just came yesterday, I mean last Friday. So
tell him to change
these are the volume, our volume numbers, as you can see. We lead the pack, and various top 10 centers volume there. The little disappointment in the sense that if you take a 3 years volume, again very high, second St. Francis, then North Shore. The double star usually we get. This time we missed it. This is for the Department of Health PCI 30-day risk-adjusted mortality. For the tower program, we actually are the 4th in the volume. Very well. More important, we double star in the readmission. So readmission after PCI is 9% for the state. We are 6.8. So we definitely get a double star on this point. But also from the physician point of view, as you can see here, that Dr. Kinney got the double star.
What is?
Yeah. I'm sorry, what?
Go back. Slide.
No, but this slide is missing. So the Dr. Kinney got the double star in. We have to look at the slide. So she got double star of very few physicians in the entire state. Got, so as I said, some good report and some not that good report. And the good report here is that Dr. Kinney had risk-adjusted lower mortality with the double star, both in patient all cases and in the elective cases. And so we, I think,
can you go back?
Was, we had to look into the slide, that whether slide was there.
It was there. There, no.
Okay.
Yeah, we have one. We have slide. So we will show that slide. Elena, maybe she can make it. So somehow this slide has been. I don't know how this. We were there today. But overall, great news. So, but we definitely have to show the slide.
Congratulations. Yeah. Absolutely consistent with my own observations over the last many years. You have represented excellence from the institution. And if there was a way to add a double star for an educator, I would add that too. So, I mean, we are seeing the list of this is the TAVR. Top 10 volume centers in New York State.
Right, but we definitely have to give the credit, and Elena will bring that slide and we put it there very shortly. So with that note, this is our usual supporter. This is case number 154. We can continue the slide. So we present the case. 64-year-old has a history of CAD with prior PCIs. Now did good since last 2010 and now has new onset angina. And stress test positive for multivessel ischemia. Risk factor clinical variables, as you see the PCI in last 2010, and EF near mildly decreased and on good medical therapy, and the cath was done a few weeks ago on March 8th, which was 2-vessel, calcific LED and multiple lesions, the RCA with ISR. So when we want to...
So here we have the left system, left main, non-obstructive circumflex stent is patent. This LED where we have the patent stents, and of course we have a moderate size diagonal which both have moderate disease. And then EF which is normal, EDP was about 14. And this is where we are with the RCA. So there's instant restenosis of that proximal stent, new lesion in the mid RCA. The PDA stent again has moderate diffuse lesion. But the PDA stent was up to the ostium, but if you see now, the whole morphology of that crux has changed. It was not like that. AV continuation looks like it is, very close, but it does not look like the ostium of the AV continuation is involved, but it just the PDA, that's the way, has some moderate diffuse disease in that stent of the PDA. And this is where we are, and tortuous RCA. Most of the calcium is in the prox to mid area.
Right. Anu, so where I could not make it out clearly, all three disease segments have previous stents?
No, only the
them.
proximal.
Only
yeah,
the
two of them. Proximal
okay.
and the PDA.
Okay, got it.
So let me see, if we play it, you can see it before the dye comes in. You can see that proximal there is a stent and PDA there is a stent.
Right, okay, yeah. Wonderful, all right.
This one, would you like to image before, or you want to? We see the heavy calcium, as you can see, tram track. Can somebody remove this?
Yeah, definitely in the proximal and the mid portion without doubt.
At good. Yeah. Look at this heavy tram track, and now the tortuosity, and then goes to distal. The only question is, at the AV continuation, there is no disease, right? It goes into the PDA proximally, and there is a stent there.
We are not sure AV continuation would have disease or no at the level of the bifurcation.
Yeah.
Could be or may not be.
Yeah, you have multiple pictures, but what else will decide? Here, clearly looks like that there is no disease in the AV continuation, right?
Not sure.
Yeah.
Yeah.
Not sure.
And
imaging wise, yes, we can do the imaging of the proximal only. We should not go all the way to the distal. We can do the proximal to understand. I mean, if we go to our old picture, because I did this stents years ago, it was fully expanded at that time.
Yeah.
We can always do the OCT now, right, Kiski?
Sure. Both the stents are only single layered, single stents.
Yeah. Yes.
Yes. Single layered stent, and I used to follow him in my office regularly, compliant, and LDL was well under control, everything was under control, no symptoms, only in the recent we started having symptoms again.
Yeah, very large RCA supplying extensive myocardium.
Since we were not sure AV continuation bifurcation has disease or no, we went with the 7 French. We have a Lima guide. The reason is same. We want to go to the distal RCA, PDA. Many time you would want like a, catheter with a good support, which is usually is a Amplats, which is 0.75 or AL1. Yeah, but then if we use AL 0.75, it would probably be very close to the proximal lesion. Exactly where we are going to work on. That's why we went with a Lima. So far it's behaving, but it only will know the support when we are working on the distal RCA. Right now we have a Lima guide, and then we will do the OCT of the proximal RCA, and then we go from there. Right? SS. Okay.
Yeah. Good. If it goes into the PDA, that's fine too, because that's where we are going to change it with the Rota wire, with this calcium.
But, what I meant is, we'll do that way. We have to do OCT now first.
Yep, good.
Okay.
And once again, no torquer, nothing at all, just trained fingers.
Yeah. So this is the run-through wire.
Your standard work-through.
The standard workhorse wire, yeah. So, good. Okay.
So we are ready for the OCT.
Yeah, so we are going to do OCT here. I mean, this is more of an academic purpose, I would say, because angiographically, it clearly looks that way, that there is all calcium on the both wall, and let's confirm it on the OCT.
Two straightaway questions coming on that I hope shockwave is at the back of your minds.
If necessary.
Okay.
I would say that will be word if necessary. Reason is because this is a simple case of the rota and then do a balloon dilatation. Now, can you do a shockwave? I think that's okay too, but it is a little tortuous whether shockwave will go without doing a pre-dilatation is questionable, and OCT actually will tell us how difficult it will be to advancing the other catheter. See that? It's so difficult there. So I would say that this is the kind of case you do a atherectomy and then if required do the shockwave. So that will be our goal, yeah.
Now, the indication will be based on what we see, the imaging, that how much calcium is there, which is a 2-quadrant, 3-quadrant behind the stent, and where means here the stent does not look like it's under expanded. We do have an algorithm that we have created ourselves. When do we do atherectomy and when do we do shockwave in the cases of this kind of in-stent restenosis? So we'll go over that once we do the
And
imaging.
this is the native also. I mean, there is a both ISR as well as the native severe calcified. Okay, we are ready for the OCT.
Yeah, good clearance.
Good.
Ready to go.
You want to bring it to the main screen later? Yeah.
Yes, good image.
Wow.
Almost
Okay.
4-0 kind of a vessel.
Yeah, big vessel. Yeah,
Okay,
a lot of
Kiski,
calcium
tell us what you see.
Sure.
And tell everybody, the question here is one, degree of ISR, second, calcium depth, and what is the quadrant.
Okay,
So
sure.
we also learned that the shockwave really works when it's a more circular calcium.
Okay, I'll show you.
Has to be more than 3 quadrants.
Yeah.
Yeah, start from the proximal part. Yeah, it's an ISR. And
Look at
More
like-
intimal hyperplasia.
Yeah, stent is expanded to like 3.2, like concentric neointimal hyperplasia, and it's another calcium.
Go back to my slide.
Yeah,
Take
fibrous
this slide first.
neointimal hyperplasia, and
And go to the center now, the mid RCA.
sure. So this is the tandem lesion of the mid RCA. So yeah, here's a like chunk of calcium, and come back to the tightest part.
Yeah, but when you say chunk of calcium, you have to say how many quadrants. It looks like
Sure.
1 quadrant.
Yeah, start of the pullback is not much. Yeah, like less than 1 quadrant. But
Yeah.
when I go to the tightest part, yeah, here is also like a little bit unclear. Looks like it's lipid because a lot of attenuation and not sharp border one. So here it looks like not much calcium. But when go to more proximal, yeah, here I can see the calcium like 2 to 3 quadrants. So now I think that mid RCA tightest part is not much calcium. Yeah, like
So
the gap-
mid RCA, there's where we see the significant lesion. We don't see a lot of calcium,
Yeah,
but
sure.
proximally we do see, but even that is 2 quadrants.
Yeah, right.
And the proximal stent is all intimal hyperplasia.
True. Stent is expanded, so the reason is the biological ISR, not mechanical.
Yeah. So he has clearly made it that it is a stent well expanded, which we knew even from the initial stenting. So it was a well expanded stent at that time. It is still expanded, so it's all intimal hyperplasia, no calcium behind the stent, and in the mid lesion is also mild calcium, mild to moderate.
Yeah.
So I think based on everything, we should just do rotational atherectomy. Is all intimal hyperplasia.
No, in the mid.
Mid is a mild calcium.
Yeah. The
One
proximal
quadrant.
is all neointimal hyperplasia.
No, 1 or 2 quadrant. Here.
No, this is intimal
Yeah,
hyperplasia.
Go
there's
for
like 2 quadrant, but this
Yeah,
is
2
the like
quadrant. Yeah, 2 quadrant.
gap part.
That's fine.
So this is not
That's
the
okay. So
tightest
good
part.
rotation atherectomy, 1.75 bar. Okay, let's change it to the rota. And with that note, actually, I'm sorry that the slide which I want to delete different slide and added some, there was a little, I call it a boo-boo, but we corrected it. We can go back to the slide, please. While getting the rota ready here, we are going to put a rota wire and 1.75 bar. Are you going to do a rota of the PD or no? No. Yep. Okay, now, so this one is the slide you can see here. The star interventionalist more than at Mount Sinai. So Dr. Keeney here, there's a double star of 2006 to 2016 to 18 with 2684. with risk adjusted, double star as well as non-emergency cases. So we're really proud to share this, the positive report of our the PCI volume, readmission, and overall status. Now, the interventional point of view, these are the number of interventionists who do more than 1,000 PCI in 3 years, and there are 17 total. And nobody has crossed 3,000 yet except myself, but everybody else is here. So this is what I just wanted to share. A lot of good positive report of the New York State. Now, as you know that after next year, 2019, there is no state report for 2 years. There is a hiatus because of COVID to 20 and 21. So the data are collected, but because of the not actual whatever supposed to be delivered to the patient's best care, we know were compromised for various reasons during COVID time. So the data they already mentioned, they will not be, they have collected the data, but they will not share, not produce those data in the future. Yeah, 3 of what balloon you need? 3 or 3.5? 3.5, yeah. 3.520 balloon. Yeah. So this is 1.75 bar. So we are still waiting for the 2019, which probably will take by end of the year, but then there will be no reporting for 2 years. Now also we learned that the PCI number has gone up. So no longer decreasing. PCI number was 49,000 in 2017 and 2018 became 51,000 and change. So there has been about 8-9% growth of PCI volume in New York State. And the same thing that we did have a little down a few years ago, and in the last couple of years, the volume of the intervention is increasing, volume of the structured cases are increasing significantly. Okay. Keep talking about what you are doing.
That's it. So I wired the Rota wire, direct Rota wire, and then we now have 175 bar. We tested it. We're just going forward.
And always
so I think it's important
ready.
Discussion that how imaging, there was a discussion, I remember, when there is intimal hyperplasia, there are 2 ways you can handle that. One, same, intimal hyperplasia, is it just intimal hyperplasia or is it calcified? Is there calcium within the intimal hyperplasia plus minus lipid? So this looks like it is just intimal hyperplasia.
But my question is, why after 10, 11, 12 years actually, there is intimal hyperplasia? Is any sign of neoatherosclerosis in that?
Yeah, looks like
you can see some lipid, he's asking.
And if you have a lipid and you have calcium, then it's likely not intimal hyperplasia only. That it's likely, so here, do your 3 steps, right? So it probably neoatherosclerosis, right? Because it's 12 years later.
Yeah,
we have the pictures on this patient in 2010.
Very interesting to see how the guide behaves there.
You want to hear about that?
Yeah.
Neo, is it neo or no?
So I show you the cross section of the tightest part, the ISR part. Yeah, there's some attenuation, so there could be some neoatherosclerosis with lipid. Yeah.
Lipid.
Yeah.
Okay. And tell us how do you differentiate lipid versus calcium in OCT?
Yeah, lipid has like high backscattering and high attenuation. Calcium should be the more like heterogeneous and sharp border.
Sharp border, good.
But I cannot see the sharp border one, so there's no calcium inside a stent here.
Okay.
Go. It's all lipid neoatherosclerosis.
So in this situation, 2 things you can work. One is rotational atherectomy, or even if you don't have access to rotational atherectomy,
1 cc neo.
Balloon.
Yeah.
Oh, LDL is 155 on the statin.
Good case for inclisiran, not only PCSK. I have put 4 patients on inclisiran now.
No, first you have to try PCSK9.
Yeah, but I think the new kid on the block is available now. Increase the pacemaker rate and give atropine 0.6 also. Yeah, that's good.
No, increase pacemaker rate.
Yeah, but
More, 70.
You see that there was little bradycardia and will not do a rota once systolic is in double digit. Now it's went up and we are ready to do it.
Okay. We finished the proximal. Now we go to the second part.
No, you didn't want to go a little more distal there?
No, I am going. I was waiting for this hemodynamics to settle down a little bit.
And
I may have to do Yeah.
Get
Now I
the
have to
pacemaker rate
just,
to 50. Atropine. Because what happened is pacemaker dependent blood pressure goes to 80, but we give atropine now, and then that is 100 plus. Yeah, native
Samin,
rhythm.
still pacing only for
Yeah.
dominant RCA and circumflex?
Right. Yep.
okay, good. Still.
Yep. Now see that with the Dynaglide, we moved it additionally forward.
I think we're good.
Why did we not have picture of?
Okay,
Good. Ready?
start coming out.
Yeah. You want to do? Have you covered that
Yes,
mid
yes,
area
all done,
completely?
all done.
Okay. You want to do one more polish, or we are
No.
ready to come out?
I think we're coming out, yes.
Okay.
Let me run through.
Yeah, actually, Rota Pro we just launched in India 2 weeks ago. Good press. Only thing is they are making it very expensive, 3 times of the existing Rota price.
Yeah,
So
it was,
on 25th, I did 4 cases. We had good publicity in Jaipur, EHCC, 4 Rota Pro cases, but they had to work out with the pricing. Can't make it 3 times. Okay, let's take a picture. Now we have done the Rota, and hemodynamics are very good, no EKG changes. And we'll take a picture and then do our balloon dilatation and so on. Looks good. I mean, again, you don't have to do too much dye here. Just idea that there is no other dissection, no perforation. So go back and use this Rota wire as a cutting balloon. We have 3.5 balloon. And since we tried to use the same stent we used previously, so it was used Xience SkyPoint. Patient originally had a Promus. So now we'll go to the same. Yeah. They actually call it Xience V. It's a, I'm sorry, Promus. There was some question about the bare metal stent also. And the PDA was definitely Promus. And we could not get the report of why BMS they called it bare metal.
and this was, you said, almost 12 years ago, no?
Yep, 2010.
So,
He had few procedures before that, but last one was 2010. You see the stent on the right side in the LAD and all those areas, they all remain good. Good.
I'm trying to
this-
go into that
I see.
PDA,
Yeah,
but
there is
there's a
very
tight lesion, yeah.
Distal disease also in the PDA, but
It's
you
not
probably will
making
need a
a-
little balloon support for that.
Yeah. Okay. Need a 2O balloon to get into that
Yeah.
small. You see, almost close to the apical part of the PDA, there's a lesion. So we're going to do the proximal RCA now. Mid. You think one stent can cover it? Probably not. 38 will not cover it.
Yeah, 38 probably will not cover it.
you
This
mean
is the
both
3.5.
proximal and the mid portion?
Mid portion, yeah.
Yeah.
So let's see. So first we do that and then we go to the PDA.
Okay, good.
Ready?
Yeah.
Yeah. This is a 3.5
Would
20.
you have even considered even a larger burr?
I was thinking before he told 175, that should we have gone 2O.
Yeah. So question
Single
comes
bar
is,
2O. Yeah.
to me, our 2O bar use since the shock wave came has become very low. Because anytime you need to go to the second bar, I think that's one also our algorithm teaching that once you go into the large bar, it's not necessary. But yeah, in this case, if you want
In
to
this
go to
case,
yeah,
after we know it was only intimal hyperplasia, we could have just done a 2O bar.
little 2
Yeah.
millimeter further. Yeah. So this one actually was a good case for 2O. Yeah, that is
Yes.
absolutely correct.
Yes.
Yeah,
That's what we were talking. Before I said 2O, you already caught 175.
yeah. So this is the 20 atmosphere.
This is a 3.5.
Down.
3.5,
3.5.
20. Okay, let's take a picture. It's working as a, score flags. That there is a one wire outside, not two wires.
Sameem,
Modified score flags. Yeah.
Here is an interesting observation. I've never noticed it like this. I've had about 4 questions and there are something like 25 chats.
Ah,
It's just
wow.
about almost converted into a chat forum, and must be also because it's so much easier for people to quickly ask.
Yeah.
Changing times, you know, automatically I used to have a reset. I was looking at questions and need to recalibrate my own reaction here.
Okay. Okay, let's put a stent now. Now, what is happening in the distal? It's a pseudo lesion,
Pseudo.
right? There was no lesion before.
That's little calcium. I think it's a pseudo lesion.
You know, maybe little open that out with the little AP cranial view.
Yeah, this is the
not
AP.
convinced. Oh,
Yeah,
it
okay.
does. It
Let's get a
already is.
balloon. You will get a balloon for the PDA. Let's get a balloon for the PDA. 3 or 20?
No, not 3-0.
Huh?
2-5.
2.5, 2.75.
Okay, 275.
Okay, 2.75.
Or you want a cutter there?
Or cutter. Yeah, let's use the, okay, then 2.75. Yeah. Wolverine, yeah. Do you want to go to score flaps?
No, I'm not going to score.
Huh? Okay. Wolverine, 275 for the PDA.
We are going to re-stent it, and what should be the length of the PDA stent?
No, PDA should just come up to the ostium. Not a
lengthwise.
Yeah.
Lengthwise.
Yeah, 2.75, 23.
No.
Huh? Or 28. The
think it'll be
question is,
20.
do we need to take care of the very distal vessel if you leave that alone?
It's not 275. I think it'll be a 2.5.
275, 23 or
2.5.
2.5, 23 will be okay. The balloon is 275.
No, that's okay. ISR, but
That's
vessel
ISR.
distal is not 275.
Okay, yeah.
I would go smaller. Wait.
So what were the questions?
The commonest questions, recurring themes was recommendations for a AL1 guide and why not IVL.
Yeah.
So two questions, similar ones asked by numerous people.
So no, question is, based on what we saw, again, remember the calcium, if you did the imaging, let's do the cutting balloon here.
Look,
No, it's not
my
going to go.
reaction there was that, you know, the awareness and the discussions
2.75
regarding
balloon,
IVL
20.
has taken absolutely center stage now.
No, but question is that if you have done the imaging and you don't have more than 3-quadrant calcium, that's where you start seeing some dissections and so. So based on that, I would suggest that this is not the ideal case for IVL after imaging. Now, if you didn't do the image, that's what we usually do, many of these cases, so that's okay. Then would have been fine. But after imaging, it does not substantiate. Yes, there is the intimal hyperplasia and the proximal stent, but from the imaging point of view, that is not an appropriate case for IVL in our algorithm. And you want to comment on that?
No, I agree. That's why after
Completely
we did,
makes sense, yeah.
yeah, after we did the imaging, I've made it clear that one, there's no calcium behind the stent strut. Two things. One, was it mechanical or biological? So we clearly said it was biological, and in biological, it is intimal hyperplasia. We also plus minus neoatherosclerosis at that level. For that, I think the treatment still would be should be rotational atherectomy. Now, if it was mechanical under expanded stent, because during the initial time there was a lot of calcium and there's a under expansion, there also again, if it is just mechanical and you need to cut the stent strut, probably you have to do rotational atherectomy followed by plus minus IVL. It's not making a turn only because the way the ostium of the...
So question comes is the AL 0.75 guide. I would say the selection of 0.75 is completely fine in this particular case. In this particular case, not the IVL at that area, but 0.75 AL would be completely fine. So what do you want to do now? Compliant balloon?
Yeah.
Or you want to recross it? Maybe it went through the
No,
strut.
no, it did not go through the strut. That is
Okay.
the way. Give me 2.512.
Compliant?
Yeah.
Okay. So what happened is you saw that 2.7520 balloon non-compliant did not go in the distal, our PDA, ISR. So we are going with the compliant balloon 2.512.
It was a longer balloon also, when I would not make the turn.
Always comes, but this is so long that it cannot be that we went through the stent struts and so, because all that area had been or develop intimal hyperplasia or neoatherosclerosis. It is just the angulation. Okay, we go now. Whether AL would have been better, and then of course by using the Guideliner would have been fine.
That's the
also.
next one. I'm going to call.
Right.
Get the Godzilla ready.
Yeah.
Yeah.
Yeah. So I think rewire now.
It's not a question
Pull
of
back. No, I'm
rewire.
busy
If you really
rewire.
need to go, we have to double wire with the fielder. It may go. See this?
Yeah.
This is not allowing anything to
Yeah.
go
No,
further.
I know, but so rewire. Pull back the balloon. Yeah, good. Rewire again. No, just go back again. You'll go back again.
Yes.
Maybe it will go through this.
Not
Credit
the-
here
Yeah.
to Dr. Harris Nagao. He had
Yeah.
recommended the Guideliner right at the beginning of the case.
Yeah. Well, I mean, you
Very
didn't
good.
need a beginning, but now means after you're done the Rota, using Godzilla is nothing wrong in that to get to the distal vessel. Because now other question is, do you want to put a stent proximally so that it's fully secured and then put the Godzilla through it distally?
Another
Or do you want a
very
fielder?
reasonable
Get a
approach.
fielder also. Yeah. I think Rota wire can come out. We don't need the Rota wire now. It's a nuisance, right? Let's take the Rota wire out.
Necessary
If you need, you
to
need
put
go
this
with a
other
fielder.
wire.
Because angulated, the run through is good, but you probably won't make that turn. So good. Okay, let's try now.
Far more support
Oh,
there
oh.
now.
Right. Yeah.
Okay, get the Godzilla now.
Okay.
And let's take care of the proximal first. Huh? No,
Yeah,
do you
let's
want to
put
put the
six.
stent proximally?
Yeah, yeah. 3.538.
Get us a 6 French.
Yep. But let's put a stent first.
No, 3.538 still may not cover the entire. So I have to
I
put
think
2.
it will cover majority. Then in the end, you put proximally later.
So, I mean, what is the longest stent you have?
Yeah, we
48,
48 is the synergy. And we are the part of the SPECT 48 trial, long stent trial of the Xience. But
You have the Godzilla open?
Yeah.
Various parts of the world, they've been having much longer stents for so long.
Yeah, 48 has been quite a bit. So Xience is available in even India, 48. All three of them, Onyx, Xience and Synergy, all are available 48 in India. We actually 48 only right now. I don't think Onyx is also even 48. The 48 is only Synergy and Xience after the trial completes. Okay. I think we'll be okay. I think it'll cover. Now take a picture.
Mm.
Yep. Cine.
Just about, yeah, it does, I think.
Yeah. Yep. Made it.
Proximally we need.
Yeah, but if required
Okay,
in the
okay.
end, we can do. Remember, there was only mild disease.
Go up.
Okay. So this is a 3.5, 38 and going to 16 atmosphere. To inflation, require optimization later. But here, we have two issues to deal with. One, the PDA. Second, the pseudo lesion, which looks like in the distal vessel. Now, vessel size was 3.5 or 3.75?
Actually, vessel size is 4.
4.0?
Yes.
Okay. So
So
then
in distal it looked 4 though.
yeah. So we may do a 4.0 post dilatation, but
Yeah.
later. Yeah, that's fine.
Okay, now.
Good. Let's get the Godzilla. Come.
Want to take a picture? 1 second.
Good. I think it covered it. Okay. So now for the distal lesion, you know, it's okay to divide into two groups. In this case, proximal and distal. And that's what we did. Did a rotablation of the proximal, PTCA, and now stenting of the proximal, and then we go to the distal.
Proximal
that
is
balloon.
absolutely pristine now.
Balloon. Yeah. Looks very good. One second. Let's get the balloon.
You probably will still need to dilate with the non-compliant 4.0 or something, or
No,
that looks
this is
good
not
enough.
going to happen. No, no.
What?
Give me the 3, oh, that's a 20, right? Give me a,
2.7520.
no, we have 3.5, right?
Huh.
3.520 was it? Okay, give me 3.520 balloon. I have to get the guideliner down. 2.0 is not going to take it. 2.5. So I saw the guideliner would not go forward, so you no need to advance it. So we need a balloon. We'll go to the mid RCA, inflate the balloon and advance the guideliner over the balloon.
Good.
Another observation we've had is so many more viewers these days from Pakistan, and welcome all of them, including Dr. Sohail Rashid. He's been very
Give me a
active
new
there
balloon.
before.
I don't like 20.
Yeah. Yeah, 20. Good. Advance your Darjila. That's great. Yep. So once your balloon is deflated, that time you advance your guideliner and Godzilla. Yeah. The wire is coming out. Good. That's fine.
Okay, go up.
So same. We go up first. Reposition your guide, your all the devices. I'm deflating. And then you. Good.
What a lovely demonstration of the technique.
Beautiful. Good. Done. Out. We get that balloon now. We have our 2.5 balloon now. We have it.
But you understood, Samir, he wanted to go directly with the PDA balloon. We knew the PDA balloon is still not going to go. So you had to do this step to get the Godzilla to the mid to distal RCA. And then now we go with the balloon. I'm still not confident it will make it, because we may need a fielder wire, double wire, yes.
I think it should, but let's see.
Yeah. It has taken that C curve out of the equation now.
Yeah, exactly.
But
that's where the issue was, and I am glad that
no, that's not the issue is the angle.
Angle of the PDA.
Angle of the PDA with the stent has created this 90-degree bend, and the balloon is not making the turn.
Good. So far, good. Okay, we are going in now. Good.
No, it's not. See that?
Yeah.
There's no way a stent will make this turn.
No, but let's make a dilate, make it straight, and then you go further.
I think there'll be a trouble with this. Okay.
Yeah, good. Okay. This is the compliant balloon, 2.5.
Good.
And then we'll straighten out get the other 2.7520 high pressure.
It's not going to go SS. Don't even think about it.
We'll go.
No.
Now get the guideliner now.
I will.
Go. Good. Let's bring little proximal. Yeah, good. That's good position. Good position.
Yeah, with the guideliner there, I think anything. You can drive a truck through it now.
So I think keep it there. The real distal segment of the PDA, we'll leave it alone.
No, see now, everything is coming out again. You really need a double wire with the fielder to make that turn. If a compliant balloon is not going as...
Okay, pull back first in the guide. Now go back again. Good. See?
Hold that.
Many times you bring it and go with the speed.
It's nothing, it's re-wrapping. Yeah,
re-wrapping, exactly.
Keep going.
Good. Ready?
Yeah, I think...
Yeah, that's fine. We can go with the stand directly.
Hold on.
Yep. See, every time the guide, wire, everything you have to think. It's not just a single process. Yeah, good. Just leave it there. Wire, don't go further. Okay. Wire will cause more damage.
Okay, go up. Okay, what's the strength you want? No. Yep. 23.
23. Okay, I'm going
osteum. Yeah. Give it to me right now.
Okay.
Okay, so now you see what I did was I got the guide liner into the, not the guide, Godzilla, into that PDA ostium where the stent is. So we have one chance to get everything in now. Bill is saying deep sea diving. Go.
Anu, are you sometimes concerned about the potential for trauma, even with the Guideliner being so deep in some kind of a tortuous segments? Again,
No, but that area we are going to stent anyway. Yeah, you're right.
No, he's talking distal RCA and yes, thrombus formation, dissection is a known thing. That's why you have to advance the Godzilla the way we showed it, and you got to be fast when you're doing this. Look at the pressure there. Are they showing the pressure? We have damped pressure. You don't give a lot of dye. Don't.
Show the hemodynamics. Advance wire a little bit. Wire.
Oh, man. We had a good position. It's not going to go now.
Good. That's fine.
Come out.
If it does not go, we get a...
No, it's not going. I don't want to push. It'll strip.
Get a
You have to go
2.75
fine.
balloon again.
Yeah, 275.
Now get the 2.75. We are not used yet. So we did only compliant balloon so far. Now we are going to go with the non-compliant balloon. Good. So key is just by having the Godzilla at the ostium of the PDA didn't help. So you need to open that angle a little more. And why that angle has been created by the stent.
Yes. When I saw the case, remember as I told you, this would be very difficult, challenging.
The big challenge on this case was the ostium of that RPDA.
Yeah.
So that when this case was selected, that was clearly the big point. So now we going with the 2.75 20 non-compliant balloon.
No, this will not make it. I should have gone 12. Get us a 12 balloon.
It will be okay.
No,
Right.
it's not going to go.
1 second.
Okay, go up. Hold on. Okay, go up now.
Yeah. No, we don't need any.
I'm not a fan of 20 length. You really?
Okay,
No,
come
leave
to
it
the
there.
ostium.
Leave it there.
No, but come to the ostium. We have to open the ostium. That's the key.
No.
Pull
Okay.
back more, little more.
Go up.
Yeah, I thought
Yeah.
the 20 is actually even going
Yeah.
beyond there.
Yeah, good. And we are
Okay,
20.
stay there.
Good. Now,
No.
deflate.
Wait. I'm going.
Yeah.
One
See,
second.
Now we are going to position the guide better, going to deflate, and then guide
Go.
Godzilla to be advanced. So what we are doing it that on the inflated, on the balloon material. Good. So this is where part of that question Samir answered, that we try to advance in the disease segment Godzilla over the balloon material. So see the balloon deflating. That time we are
Absolutely, and
advancing
use,
it. Yeah.
Use that motion to.
Yep. And then you're going to stent that area anyway. So that's the two things to avoid the Godzilla and injury. Second, if your pressure is damped, make sure you do a slow injection. A third, that if you're doing an auto with the injection pressure, assist, that you decrease the pressure to like 20 and very little injection, because there always the damped pressure, as you can see there, and that is all part of the occupation. That whole area is occupied by the Godzilla. So that's why pressure tracings are damped right there. Came out again. Yeah, so this is the guide issue.
So, I mean, there is a very interesting question which I think will benefit our overall audience. This is by Dr. Arun Nagarajan. I'd like to read it exactly how he is. I'd like to ask Dr. Sharma and Dr. Kinney about the use of Rapiscan for FFR. Does it have a major benefit over adenosine? I have been using it widely in our cath lab. Any opinion from both of you?
That is for the RFR?
He writes here FFR, Rapiscan for FFR.
What is Rapiscan?
Rapiscan. So
listening, he will clarify.
Quickly check up to date.
Yeah.
Now, do you want to go for double wire fielder?
Yeah, okay. We go
But
double
for
fielder.
that, we have a different.
Give yourself more ammunition to get it down there.
Fielder wire first. Yeah. So I think what happened is we are going to do all the work on the fielder wire. You leave the Godzilla there. Good. Let's go in with this. And we'll see where it is going in. So double wire with the Guideliner will accommodate 2 and one single stent will be okay. Up to 3 or 3.0. Once you start getting 3.5 and above, is it a
6 French will be double wire, will be an issue. Now you need to show me the entrance of the Guideliner.
Yeah.
Ostium of the Guideliner. No, you're a cranial, move it.
Good. That's okay. Go. So we want to make sure that this wire gauge doesn't buckle up. You see there? Yeah. No, pull back. Yeah. Inside. Yeah. No. Yeah. Good. See that? So advancement through the
ostium.
yeah. So now you can move the Guideliner back.
No.
Don't need that high.
See the tip, you needed it very well. It's going into the AV continuation.
Yeah, other question comes is that do you want to remove the Guideliner, just keep 2 wires and then try
It's
on
not
the
going to go.
fielder wire.
You can do that.
No, but what happens is Guideliner is pointing you in a different direction. You have to pull back the Guideliner quite a bit. Yeah, now.
So
Looks
this,
like the curve. Yeah, good.
You mentioned
Very good. Get the balloon again.
it's a
No,
reg
275,
adenosine
Now
analog.
give me a 12 balloon. Yeah.
Oh, reg
12
Darson.
high.
So they're saying, yeah, okay. Yeah, instead of adenosine, people are using reg Darson, which they use it for in our stress MPI and pharmacological. So yeah, that people have used it also. Yes. But we haven't used. There are some publications on that instead of adenosine, less side
Is
effects.
it a regular or
less
high
bradycardia.
pressure? Please.
Yeah, that's good. Yeah, you need high pressure. Yeah, we'll go.
Not going to
So
go.
that one can be used also. But question is, if there is an issue about the adenosine, a lot of people have converted into the IFR, which is fine. And the
yes.
data actually have shown 3 to 5 years that FFR, IFR long-term data were okay.
I did
Just
not
to
want any of these things.
clarify,
Can you give me a
it's,
2, 5, 12 balloon?
Arun
Regular.
Nagarajan is from Ireland and a nurse. Arun, thank you for your questions.
2, 5, 12 new.
So we are going with a 2.512 compliant balloon.
Compliant.
Okay, we had that earlier, but
We
want to go
used
with
it,
the new
no?
one. Yeah, we go with the new one now.
Yeah.
So we still have to get over that hump,
Yeah.
despite the 2 wires. And now we are going on the fielder, because all this not a very stiff wire, our run through, but it will cause definitely more wire bias, and being a hydrophilic fielder will keep it more in the loop. Good.
The question is whether you'll need to deep seat the Guideliner again.
No, we will have to, but to do that, I need this
to
balloon
first
make
get
it.
Okay,
Yeah.
there you go. Almost made it. Almost there.
Okay, go up here, SS. Let me get the Guideliner there. Go, high pressure and hold it.
This is a high pressure
Good.
balloon you have.
No,
No.
this is the
High
compliant
pressure
balloon,
again would not make a
2.512.
turn.
Compliant.
So,
Huh?
yeah, so
Okay, good. Down.
okay, go advance more.
Okay, go up
Okay,
now.
good. Your other wires.
SSB.
So truly has turned out to be a case how to use the Guideliner.
Yeah.
Okay, now go.
Yeah. Good. Okay. Make sure
Okay,
your wire remains
I
distal.
know. We have to do it without the wires.
Good.
Okay, now get that stent.
Yeah. Do you want to remove the run through now?
I think let's keep it.
Okay.
Or remove the run through. May not go. Double.
Yeah. It
right?
will create a lot of difficulties
Okay.
because your fielder wire is in a good position. Your guide Godzilla is in good position. Let's see.
Take it out, right?
Yeah, fluoro. Yeah, I think we remove that. Less friction. Good. Keep this wire. Okay. Take 2. Now we are going
No,
back.
3 or 4.
No, with the stent. No, but the stent is take 2.
No. 3.
With the balloons, yes. The stent is take 2.
3 yes, we tried.
Huh?
We tried 3 times. Good.
All right.
Go.
So now we have Godzilla in the PDA. We have a fielder wire and going with the same 2.523 Xience sky point. With the wire a little further. The wire quite a bit coming out.
Yeah.
Although a little tenuous position. Good.
Final. So you see it was a fielder, okay? Okay, now we don't say, I'm going to pull the wire back, but it's in small branches.
And
And
put the
then
Godzilla
put
back
the
in the
Godzilla
guide.
back.
Yeah. We don't need Godzilla for anything now.
Okay, now pull the stent back a little bit. No dye, I think we'll just go, don't give. We'll see where the osteum is, right?
Yeah, probably.
Question
get
is-
that Godzilla out, take a picture, and then position
Huh?
the stent.
Yeah.
The pressure is okay. So you can give little dye.
Okay.
Shift, give little dye. Just a little dye because we have to see how the crux looks. Yeah, looks good, right?
Okay.
Okay, we'll be across the AV continuation now.
Don't
Go
want
up.
to come back a little bit?
Yeah.
Okay,
Then I
take
would
a
still come
cine.
back.
Then take a cine.
Then
You
cine.
want to hear everybody
Okay. Yeah.
not sure?
All
then
right.
Take a cine. Good. All that we are seeing is because of the wire bias. Okay, go up. The distal RCA.
And there we can do a little balloon here.
Was
Where?
this a
This last
275 or?
No.
It's a 2.523.
Take out the wire, take out the Godzilla, everything will be back to normal, but we need to post the proximal RCA.
With a 4020 or 4030. We can use 30 because we have the.
It's not going to
long-
make a turn. You guys are like balloons. Okay, I'm going to leave it here.
Yeah. Take the Godzilla out. Take this out.
1 second. Okay, ready? So I'm having the soft part. Only worry is the distal PDA.
Yep.
Go. Oh. Looks good.
Yeah.
Anything there of concern in the?
So there was
segment
always a
distal to
mild
the
disease.
stent?
There was there was always mild
Always
disease
mild
there.
disease. See, remember in the original picture also, let me just show this very quickly. So we always have that mild disease distally. See here. See that? So now, it has, because of the step up, looks a little more. But I think that's okay. That I'm not concerned now.
We
Only
should not
question
go
is
back. No,
dilatation.
we just go post dilate here.
Yeah, good. 4.
But you see that the distal RCA, what all things we saw, it was all wire biased.
Yeah. Yep.
Well, once
Good
you've
point,
given some more nitro, things will
Yeah.
look a whole lot better.
Okay, yeah. So they're doing a 4-hour dilatation and then we'll be ready with OCT. The main purpose and teaching is here done. Let me go with my slide presentation.
Yeah.
Here.
Go.
And this is the 4 hours. Then
We are going
by
to
the
just
time
post
I
dilate
was-
and OCT.
OCT time, sorry, once the OCT time comes, I will come back here. Okay, we go to the slides, please. So, based on this particular case, a patient does make full criteria of high risk
Sometime.
finding, intermediate or high risk with double anti-ischemic therapy, so it's appropriate to do the PCI. The 2 points, one, interventional trials from ACC 2022. I can tell you there was not much shown on the intervention. There are many others, but not on the intervention. So flavor trial, 2-year data, FAME 3 trial, quality of life at 1 year, and complete trial, quality of life at 3 years will be shown. Then focus review of the month will be 2021 coronary revascularization guidelines, which is the updated ACC-AHN SKY guidelines for coronary artery revascularization for both PCI versus cabbage. There has been a lot of controversy and I'll talk about that, what has been. The flavor trial was a trial comparing in intermediate lesion FFR guided PCI versus IVUS guided PCI. Remember there was a trial which I showed few years ago called FORJA. FORZA, and that was FFR guided versus OCT guided. And OCT data at 1 year were better than FFR guided. So this is the trial where in the intermediate lesion, the patient came for the cath possible, and then they decided whether to do based on the FFR or IVUS to do the intervention. And hypothesis was one FFR guided PCI will be non-inferior to IVUS guided PCI. So randomization was done after the angiogram with the regular inclusion exclusion criteria in a 2.5 millimeter vessels. So what was the plan? PCI was done in these cases. FFR was less than 0.8 in the FFR group, and IVUS they had a lumen less than 3 MLA, or if it was between 3 and 4, but plaque burden was more than 70%. They counted that as a significant. So those are the cases where got PCI, other remain in the medical therapy. Then optimal PCI was done, that your FFR was more than 0.88 in that group, or there is a very little decline of FFR of less than 0.05 across the stent. In the IVUS group, it was that stent area was at least 5.5, or minimal stent area was more than distal reference area, so full stent expansion. So this is a trial of about 1600 patients with a 99% follow-up at 2 years. What did we find? That FFR guided PCI led to a FFR guided group had a PCI in 44% compared to IVUS guided group has a 65% PCI, and clearly stent length, stent numbers will be respectively lower. So outcomes at 2 years exactly over, as you see, the identical. IVUS group 8.5, 8.1 FFR group, that was death, MI or any revascularization. So absolutely no difference. IVUS was FFR guided. Individual endpoints are shown here. Again, no difference at 24 months. Now you say, well, what happened in that group? Remember, each group, like 55% in the FFR group, 44% in the PCI group did not have the intervention. In the IVUS group did not have PCI. So in the medical treatment group, where they did basically again supported that at 2 year event rate was very small on medical therapy group, about 5% in both. And when you did PCI, of course, it went up and was slightly in the FFR group 2%, but non-significant. The second, they say optimal. We always talk about get a good optimal FFR, IVUS, and so it shows that whether you get optimal or optimal, there was no difference in the both the optimal IVUS or optimal FFR group. And individual endpoints are this also showed no difference. Prediction and SAQ score, both studies gave a good decrease in angina frequency and the quality of life parameters. So basically showed that PCI of the FFR guided PCI was non-inferior to IVUS guided PCI with less use of stent, and there was no difference in patient reported outcome between the two strategies. Second, there were two studies of the quality of life. One after FFR guided PCI versus CABG in FAME3 trial, and then was the second was the complete. We showed that FAME3 trial last year that FFR guided PCI versus CABG in multivessel disease non-left main, PCI was inferior to CABG at 1 year outcome of the death, MI, stroke, and revascularization. So quality of life outcome was basically studied, have been done in the past, and they are better in the CABG group, but they were never done with FFR guided or new generation stent. So this was a unique in terms of getting a quality of life perspective. And the goal of the study was to compare the effect of FFR guided PCI versus CABG in the health related quality of life outcome self-reported. This is called EQ5D, which is developed by Euro Quality of Life Group. And what were the 5D were? 5 dimensions of the health status: mobility, self-care, usual activities, pain and discomfort, anxiety, depression on a. And this is reported by the patient at the baseline at follow-up. And these were the comparison at 12 months, and then individual endpoints for working status and various subgroup categories as shown here. So very interesting that while the EQ5D summary index was identical, you can see here rapid recovery. So in the PCI group, so quality, the summary index was faster at 1 month compared to the CABG group, which took a little extra time. And these are the other summary index in terms of improvement. Angina class were identical in both the groups, and very important, the return to work, working full-time or part-time, as you can see here, was kind of a little favoring PCI, but more important, they have pre-specified in the younger people, less than 65. You can see significantly higher people went back to work after PCI versus cabbage. Very, very interesting and positive actually for us to tell the patient who want to return back to work in full activity that PCI did a better job to getting them quicker and get back to the work. So very interesting. Individual endpoints of the summary index were not different. So basically, idea was that the PCI, the quality of life 12-month is equal in both of them, but more importantly, the PCI led to a faster improvement in quality of life and improved working status in patients less than 65 years of age. The rate of significant angina was greatly reduced and was not different between the two groups. So this is paper will come out in circulation. Then the complete trial of STEMI, whether you do a culprit lesion revascularization or complete revascularization, they have a quality of life comparison, improve angina related quality of life, and that was the part of this complete trial at 3-year follow-up. And basically, to look into this aspect, that how many patients had baseline, as you see baseline were identical, and then what happened at follow-up. We also know in the culprit lesion group, lot of people then had a PCI later on, compared to in the complete revascularization, very low event further on. So almost 15-20% of patients went in the culprit lesion only to have a PCI at follow-up, but group was put as together. Now these are the SAQ subscale at 3 years of angina frequency, physical limitation, treatment satisfaction, quality of life score, and summary score. All of them you can see the culprit versus a complete revascularization was better improvement in the complete revascularization compared to the culprit group. Then the angina status at the steady end, that you can see culprit, the absolutely free residual angina was 12.5 versus 15.7%. So there was clearly different favoring complete revascularization. And so now also very interesting observation came that in the group, when the non-culprit lesion was more than 80% or less than 80%, remember inclusion criteria was between 60 and 80. So it has to be more than 60. So if you take patients who had more than 80% visual estimate stenosis of the non-culprit vessel, the benefit of complete revascularization was only in that group, not in the if it was less than 80%. So presence of more than 80%, benefit of revascularization was there complete compared to culprit revascularization only. And this is basically the change from baseline was 9.7 versus 8.9. Other groups were not different. The same way for the angina frequency and so. So they basically studies show that if you have more than 80%, complete revascularization did a better job of angina relief compared to if it was less than 80%. So benefit of complete revascularization was angiographically more than 80%, you did better in terms of quality of life parameter. Besides, overall, as you remember the trial, complete revascularization was better than complete compared to culprit lesion revascularization at 1 to 3 years. So basically this was the summary, that although both techniques did better job of improving quality of life, but complete revascularization did a better, more angina free patient, and it happened only in group when the non-culprit lesion stenosis was more than 80%. So clearly that if you want to, for some reason, for kidney status and so, you want to leave a 60-70% lesion alone, even in the complete revascularization group, it was okay. So this is very important. Then total angina burden from randomization to follow-up, related events and residual angina at steady end was substantially reduced with the complete revascularization. So clearly, complete revascularization did the better job of angina relief besides having an overall better outcome. More importantly, the benefit was only confined to the lesions when it was more than 80% and so. So with that note, Anu can update us what they have done so far. Yeah. Okay. So we are ready with the OCT. Show the picture of the post dilatation.
Are you done with the slides?
No, I have one more. Continue.
No. We have finished. then we can close the groin.
Samin, before you go to the conclusion of your presentation, two remarks. One, of course, the complete quality of life is really unsurprising. Although it's good to know that now we have a differentiation at greater than 80% those benefit. But again, why should that be a surprise? I was more fascinated with flavor, which is really comparing physiology versus imaging as a parameter to do it. And I thought in terms of that, the results are absolutely fascinating that ultrasound, that imaging had such a relevant part to it.
Yep, absolutely. Yeah, no, definitely. So question always comes up. Yeah, okay, sorry.
Look,
you're good?
Angiographically, Anu, it looks pristine. Let's see image guidance here.
Hold this.
We didn't do it?
The distal in particularly looks very nice.
Put on the main screen, no?
Okay, put on the main screen, OCT.
Yeah.
Okay. Ready, right?
And I'm assuming that you did some post-dilatation proximally.
Yeah, we did 4-0.
4-0.
Okay, yeah.
Yeah, great image.
All right.
Checking.
Excellent stent apposition
great.
throughout.
No dissection. Yeah, well expanded. Great.
Proximal looks good. Yeah.
Get your red color.
So
No,
check
the
your proximal
proximal edge, maybe a little bit.
So I show you okay, this is the proximal edge of today's stent. A little bit dissection, but I think it's minor.
Acceptable.
The 2
Yeah, I
o'clock
think so.
position.
Less than 2
Yeah.
millimeters.
And it's not come to the media, so it's a minor. But other part is all expanded, and the distal edge is also perfect.
Now the ISR, go where the 2 layers of stents is
Sure.
and just make sure that we are fully not there. Where the ISR is, you're going too proximal.
So
Come back.
All stent is very
Yes.
focused.
Yeah,
So
yeah,
like
right there.
here is, I can see that like 2 layers. Yeah, but really expanded.
Very good.
Yeah.
Area is like more than 9.
So I think we clearly shown when you have in-stent restenosis and intimal hyperplasia, how do we take care of that compared, that is biological restenosis versus mechanical. That's what we wanted to show. Now going back to, go back to the dissection so people are clear when
Give
we
the
have to stent
criteria of
it
the
and not
dissection
stent
which
it.
can be left alone. That people always ask 2 millimeter, whether go to media, what is the obstruction, and so. What is the length of that dissection?
Sure. The longitudinal length is actually like around 2. Yeah, but the angle is like I think less than 60 degrees.
Yeah.
And
So essentially 3 things have to be there. One, angle has to be more than 60. Show them it's less than 60. Length, I still don't know. It is 2 millimeter. Is it?
Like here. Yeah.
Yeah, it's not here 2. Yeah, it's not. It's not 2.
We are
So the length has to be more than 2 millimeter, or more important is it going deeper down to media or adventitia? It's not. It is just intima. So in all this situation, we can leave that alone. And we always go with angiography. Angiographically, it looks very good also.
I mean, you are just picking up with
Yes.
sophisticated resolution and imaging. We are picking up things which we have left alone for decades.
Yes, I agree with that.
And actually that's shown in the iLumen 3 also, that you found more dissection in the OCT group compared to angio group, but outcome and the minimum stent lumen was no different between 2 strategy, and the outcome was 6 months. They've only presented 6-month data, no difference in the events.
Okay, we can close.
Okay, so we can continue this is a fantastic case
Just to
presentation.
complete total contact, you use was 140 and AK of 0.9 with the DAP of 73, which is very low.
Beautiful. All right, let's go to our completion. The part 2, which is a focused review of the month, the updated guideline, revascularization guidelines, which Jennifer Lawton and Jacqueline Tamas, she's in our system at Mount Sinai Morningside, and a lot of other writing committee members, which included cardiologists and surgeons, as well as, of course, the interventionist as shown here. So what is the difference? I'll just go rapidly. One is they have actually a lot of emphasis on improving the equity of care in revascularization. Remember, it's always said the underprivileged female, the non-white people do not get appropriate revascularization, and so idea there is that in patients who require coronary revascularization, Treatment decision should be based on clinical indication, regardless of sex, race, or ethnicity, and efforts to reduce disparities of care are warranted. As you know, this has really gone to a very high level, and the shared decision making, which they put a patient-centered care. So you take the consent, then you have shared decision, particularly not only with the among ourselves, the patient and the family. Very, very important. So you need to have tell the patient all the benefit, and then patient is the ultimate decision maker, that what is the right thing to do, but you have to provide all the data to the patient. Then, of course, pre-procedural and post, all those things are very, very important. There are a lot of emphasis on the post in terms of the psychosocial interventions, pharmacotherapy, managing the cardiovascular risk factors and assessment of outcome, and the cardiac rehabilitation. So the assessment and predicting patient risk, things were the same. Recommendation for the heart team in the complex cases. Recommendation to predict patient risk of death with CABG is STS risk calculation. Then for CAD, for the PCI group, you calculate the syntax score. And then more importantly, many things which are not part of these various parameters of the scores, like cirrhosis, frailty, malnutrition. We need to take care of the patient as such, not necessarily by the score only. So they put all emphasis to all of them together. Now, physiological, FFR guided PCI has become class 1 indication, which is good. And if FFR or IFR is negative, PCI should not be done. They made it class 3. Second, IVUS for lesion assessment, it is 2A. Compared to FFR is class 1. Assessment is the IVUS on pre. I'm talking about PACE a little later. Pre is 2A, the same 4 millimeter square or 3 millimeter square and so. So this is a very controversial one, and that is the revascularization to improve survival in ischemic heart disease compared to medical therapy. So this is basically goes down to our various points. Patients who have left ventricular dysfunction and multivessel CAD, left main disease, multivessel CAD alone, stenosis of the proximal LAD, or single or double vessel not involving the proximal LAD. So what is basically difference, what we were taught in the past, or recommendations were, the 3 vessel disease, patient should go for CABG, because CABG improves survival. So what has shown here is that you can see in the level 1 is the green, that there are 2 groups of patients. One is the left main disease, sick patient, and second is patient who have multivessel CAD has a low ejection fraction. But if your ejection fraction is, if you have the patients not a low ejection fraction between 35 to 50% or normal, so those cases are 2A for both PCI and CABG. So I would say, because of the multiple trials which have been done comparing PCI versus CABG, and overall outcomes are similar, except maybe in diabetic, although they did not include that separately here. So it just puts it together that patients with multivessel CAD and do not have a severe LV dysfunction less than 35, your 2A indication of both CABG and PCI. That's a great. And same thing, that patients on left main disease, in which basically they're saying that also PCI has become 2A, no longer class 3. So left main CAD, CABG is class 1, PCI is 2A. Now the multivessel CAD, as you can see here, that if your ejection fraction is okay, or proximal LAD, PCI as well as CABG are 2A indication, 2B indication. Now, once you have one or single vessel disease not involving the LAD, so they actually put it no benefit or harm. That basically those patients should be controlled on medical therapy. You can do a symptomatic improvement for symptoms, but not to improve the survival. So very important. This actually have put into this nice algorithm graph which can be used. Then patients with a complex disease. So patients with a refractory angina, despite medical therapy and significant CAD, revascularization is recommended, because we do know medical therapy is bad for these patients. Patients with diabetes, look at this now. Patients with diabetes and multivessel CAD with involvement of the LAD who are appropriate candidates for CABG. CABG is recommended as a class 1 indication. But PCI, diabetes with multivessel CAD amenable to PCI, if you can do, it's a 2A indication. And same thing goes down to the left main. Lower intermediate complexity of the left main is 2B from the PCI point of view, as well as an alternative to CABG. So basically, PCI level has been elevated based on the various data so far. Now, radial class 1 indication for patient both acute coronary syndrome as well as stable disease. So that's a very interesting. So they have made it a class 1 indication or radial approach because of the decrease in vascular complication and bleeding. Now I was imaging. Now maybe I'll get your comment on this. Now we have enough data now with a long-term outcome in a complex cases, left main disease, ultimate trial and so showing, and we have showed data here that I was guided PCI have a lower mortality at follow-up, but based on the various categories as you see here, whether it's in-stent restenosis or it is the left main or complex CAD, it still remain 2A, and OCT is alternative to IVUS. The question is a little disappointed that at least in left main they should have made a class 1 indication. Anu, you want to comment?
For optimization.
Yeah. Now remember, yes, the data are that IVUS guided left main stenting, which is routine, which we do it all. Many data non-randomized have shown improved survival. The question is why they did not make it to the class 1 indication from the IVUS post procedure. Okay, so now let's continue. Calcific lesion, they actually have the rotational atherectomy and then say 2B as an orbital, or balloon atherectomy, intracoronary lithotripsy, they kept it as a 2B. So for calcific lesion, nothing class 1, because there is no data to improve survival and on long term. So it's a plaque modification with the Rota as a class 2A, and other devices including lithotripsy is 2B. Patient with ISR, they clearly say that once you have first ISR, you do a second stent. That is the best, as long as patient take the DAPT. And of course, many of these patients can go for the cabbage if necessary. And brachytherapy has become 2B. Hemodynamic support in complex PCI 2B, not 2A or 1. I know Protect 4 trial ongoing, but at present hemodynamic support in complex PCI is made as the 2B indication. Now there are a lot of data on the preventing the contrast-induced injury. As you see, particularly they besides hydration, they talk about the radial high dose statins and so. So P2Y12, nothing unusual. It's the same way which was that 6 months for the DES in the elective case, stable cases, acute coronary syndrome 1 year, and they actually had not made that you can stop one of the antiplatelet therapy after 1 to 3 months. So we have the data, but they just say that you can stop the aspirin after 1 to 3 months and continue any P2Y12 monotherapy. Compared to Twilight, which was the trial of the ticagrelor, here they make it general that after 1 to 3 months, patients with high bleeding risk, you can stop the aspirin and just continue your single monotherapy of any P2Y12. And with the AFib is a combination. Very important on the cardiac rehabilitation and education of the patient. Very important patient to be educated about cardiovascular disease risk factor and their modification to reduce cardiovascular event, besides having a comprehensive cardiac rehabilitation and smoking cessation. And they actually have put the psychosocial risk factor in the prevention of subsequent disease. So clearly, the lot of emphasis on various aspects of the patient care, not only in the lab, outside. So now let's come up to the conclusion of today. FFR versus IVUS guided PCI 2-year POCO, and the flavor trial was identical. There was no difference between two strategy at 2-year follow-up. Then quality of life improvement post FFR guided PCI versus cabbage in the FAME3 trial. Again, both were equal, except that FFR guided PCI had a faster improvement in quality of life and better return to work in younger patients of 65. So thumbs up. Then angina quality of life with complete versus culprit lesion PCI. Again, no difference. Both had an improvement in angina quality of life, except higher angina free at 3 years with complete revascularization in patients where the non-culprit lesion was more than 80% stenosis. So updated 2021 coronary revascularization guidelines emphasize heavily on heart team discussion, calculation of STS and syntax scores, equity of care and patient level cardiovascular risk education, and aggressive modification. In view of multiple trials comparing PCI with cabbage, class 1 recommendation for cabbage are left main CAD and multivessel CAD with low EF. In other patient subgroups, PCI and CABG have both 2A or 2B indications for revascularization. So quickly, three questions. Following is a false statement about the 2-year results of the flavor trial. Primary endpoints were similar between IVUS and FFR group. Deaths were similar between IVUS and FFR groups. Lower MI rates after FFR versus IVUS groups. POCO event rates, patient-oriented cardiac event, composite events rates were higher in PCI versus medical therapy in both strategy group, and SAQ scores were not different between IVUS and FFR group. So answer there is C. The lower MI rates after FFR versus IVUS is wrong because MI rates were identical between two. Question number 2. Following statement is false regarding the FAME3 trial health-related quality of life outcome at 1 year. Quality of life parameters were similar after FFR guided PCI versus CABG. FFR guided PCI resulted in faster improvement in QOL versus CABG. Significant angina was greatly reduced after both FFR guided PCI and CABG. Angina reduction was not different between FFR guided PCI versus CABG, and working status improvement in patient less than 65 years old was not different after FFR guided PCI versus CABG. And clearly the wrong answer is E. That clearly patient less than 65 has went to more working status improved. They went back to work in the PCI group versus CABG group. And the last question, following statement is false regarding quality of life sub-study of complete at 3 years of complete revascularization versus culprit lesion. The both strategy resulted in improvement in angina quality of life from baseline. There were high rates of crossover to non-culprit lesion PCI in the culprit lesion only group. Higher angina free in culprit lesion group versus culprit lesion only group. Benefit of complete revascularization was seen in all patients with non-culprit lesion stenosis less than 80 or more than 80, and the total angina burden was significantly lower in complete revascularization versus culprit lesion revascularization strategy. And answer is D. That benefit of complete revascularization is seen only when the lesion stenosis was more than 80%. Others, angina-free, angina-less burden was seen in the complete revascularization. With that note, I complete my presentation today.
Samin, very impressive, very comprehensive. Only you can do it at such a speed. I think the guidelines have far-reaching implications, and at some stage we should revise and repeat this topic. Anu, great case. Any final words from you?
No.
Okay, excellent. I hope our viewers have found the case useful, particularly with the use of the Guideliner, particularly in this case. I think of all the cases where we have demonstrated it, this probably was the most instructive. We'll finish here and see you during our next transmission on May the 15th.